So, good afternoon everyone. So, I hope everyone has revised our last class on visual pathway, right? Where we have discussed till optic chiasm. Yeah, so where we have discussed till optic chiasm. So today we move forward beyond the chiasm, that is the retrochiasmal visual pathway, right? In medicine, we diagnose with symptoms, whereas we ophthalmologists, we diagnose with the shadows. Yes, the shadows of the visual field defects. Don't think these are too boring. I'm going to make it interesting with some interesting stories, okay? So, beginning with our first case. One day, a 59-year-old male patient came to me all worried and tensed, telling me that, "Doctor, I was on my way to my office. I was all driving. Sorry for the interruption, children. Technical issues. Yeah. So, one day a 59-year-old male patient came to me all worried and tensed, telling me that, "Doctor, I was driving to my office and it was all good in the beginning, but all of a sudden I couldn't see anything on my left hand side. I checked his vision, it was normal. I checked his pupil, there was no RAPD. And from the last class I've already told, if there is any lesion in the retina or optic nerve, it might present you with an RAPD. But there was something else which I could find out. What is it? It was a Wernicke's pupil, and on examining the visual field, I got something like this. It is a left homonymous hemianopia which is incongruent. So, in our retina, that is represented by nasal and temporal retinal fields, whereas which is congruent to the nasal and temporal visual fields. Here the fibers coming from the temporal fibers will go to chiasm and then they move to the same optic tract. Whereas the nasal fibers, they reach to the optic chiasm, they decussate there and go to the optic tract on the opposite side before reaching the lateral geniculate body. So, from this, where do you think our lesion is? Anyone? Yes, it is a right optic tract. So two things to keep in mind, that in any lesion that is happening after chiasm, the left goes left and right goes right. And any lesion beyond the chiasm will produce a contralateral visual field defect. Good? Okay. One day, I received a call from my neurology colleague telling me that, "Doctor, I have a patient of epilepsy telling me that I have some visual complaint." That patient came to me. She was a 30-year-old patient with a non-case of epilepsy telling me that, "Doctor, I can't see anything on my right upper end." And she was giving a complaint that she can hear some noises. When I turn around, there is nobody. And also, I would correlate with another person who was a non-case of atrial fibrillation producing me the symptoms that, "Doctor, I can't see anything on my right lower end. Also, if I close my eyes and feel what is in my hand, I can't make it out." So, somewhere in our brain, the areas are affected and the corresponding visual fields was something like this. To know about it, we shall discuss its pathway. And here, in this pathway, we know that from the lateral geniculate body, the third order neurons will start from there, reach the internal capsule and make a forward bend to reach the optic cortex. And the dorsal fibers, which represent the lower retinal quadrant, will move directly to the occipital cortex. So any lesion here will produce a pie in the sky and the pie in the floor lesions, right? So, coming to the last case, which will make it more interesting for you, this was a 45-year-old female patient who came with a complaint that a difficulty in visual field, and she also told that the complaint of visual hallucinations. So, when I did the visual field effect, I could see something like this. This is not the same image as that of the first one. Here, it is also a left homonymous hemianopia, but with central sparing. So, to know about it, you should know the blood supply. Sorry for the technical glitches. And in this, we know that our occipital cortex, which is supplied by the posterior cerebral artery coming from the basilar artery, and the middle cerebral artery, which is coming from the internal carotid artery. In this, the cortical area will be represented anteriorly by the posterior cerebral artery alone, and posteriorly and the posterior part is accompanied by posterior and middle cerebral artery. So any lesion affecting the posterior occipital cortex will bring about left homonymous hemianopia with the central sparing. And also the latest advances shows that the OCT interpretation of patients in multiple sclerosis will provide an early and accurate determinant in detecting the lesions in multiple sclerosis. So I wonder, my children have not yet asked the first case symptom, first case assessment, that is the Wernicke's pupil. Why? All are aware of it. Huh? So I think this should be taken, and this we shall discuss in our next class. Thank you.
Ma'am, I had a question.
Yes.
Why the lady with the pie on the floor, the visual field was understandable, but why was she seeing hallucinations?
Because as we all know,
I don't know.
Okay, my children are so good that they're open and telling me that they don't know. It's okay. In that case, we told that we should first know. According to the symptoms, it can be two types. That means in that case, I have discussed the involvement of parietal and temporal lobe. So we should be knowing the basics of anatomy, where the lobes will be corresponding to the conditions that will be representing the visual hallucinations. And if the patient is having involvement of hippocampus, the same patient can tell the complaint of memory loss. That means she will be able to tell you, but not the exact thing. She will be telling short-term memory loss complaints also.
Ma'am, I was going through this question. I couldn't search the answer for this. Why the lesion in the macular spared does not have any visual symptoms? The lesion affecting the occipital part does not have any visual symptoms.
Yes, I think my students have listened well to my class and asking a very good question. Yes, in occipital cortex, it is only the macular area which is represented, and that macular area is supplied by the posterior cerebral artery and the middle cerebral artery. So when the blood supply is lost most posteriorly, that means posterior part is mostly supplied by the posterior and middle cerebral artery. So if that area is affected, the middle cerebral artery will be supplying that area, so that the patient will not be having any defect. Whereas if the anterior part is affected, the patient will complain of the visual defect that she can't see that area.
Thank you, ma'am.
Thank you, everyone.
One question. Okay.
Teacher,
Oh, yeah.
I want to understand if there is a homonymous hemianopia,
Yes.
what will be the diagnosis of this patient?
Which one? The first case?
No, that homonymous hemianopia, the left homonymous hemianopia.
Left homo. Okay, that first case where I have told my patient came all running and tensed. Okay, in that we should suspect any, since it is a sudden case, we should suspect the cause of any stroke, since the patient was hypertensive. His vitals has to be checked. That means the systemic blood pressure has to be checked on the first visit. When he came tense, no need to look at that time because he's already tense. Once he's settled, it's very important to check his BP so that we can know better and earlier than any medical